Thank you, Begum, for your introduction, and I would like to thank Breas for this opportunity to talk about this topic that, in my opinion, starts a new era, the ventilator integrated polygraphy. I'm sure that many of you are familiar in using ventilator softwares, and I'm also sure that you have always to deal with tracings like these tracings, with complex tracings, with periodic flow reduction. And the question when you see this tracing that are asking yourselves probably is this: what is the patient doing? In other words, we need more information about the ventilatory pattern of the patients, about what is the patient doing. In the sleep lab, we have a lot of possibilities to assess what is doing the patient. For example, with parasternal EMG, esophageal pressure, but perhaps the most stable and the easiest way to get this information is with thoracic and abdominal belts, like in this tracing. In fact, in this tracing of the sleep lab, we are able to classify all the signals in three main groups. First group, the pressure and flow curves. That is what is doing the ventilator. The third and fourth is the signal of the thoracic and abdominal belts that informing us what is doing the patient. You can see that in this period of flow reduction, the patient do nothing. And finally, the two last curves corresponding to the oxygen saturation and transcutaneous CO2 are informing us about the consequence in arterial blood gases of these patient ventilator interactions. What is the technology beyond the belts? Usually, belts work with the inductance plethysmography technique that is based on the Faraday's law, in which a current applied, a low voltage current, like small batteries, is applied through the loop of wire, generates a magnetic field normal, 90 degrees, to the orientation of the loop. And the patient usually wears a belt like this, fitted with a wire inside, around the rib cage and the abdomen, providing information about the abdominal and thoracic compounds of the tidal volume. But it's important to remember that in sleep medicine, in the spontaneously breathing patient or the patient under CPAP, belt signal is considered a surrogate of the effort. But in the ventilated patients, it's not always like that. For example, in this situation, you have here some cycles with effort measured by parasternal EMG, and here the signal of the parasternal EMG decrease, and the controlled cycles corresponding to backup frequency appear with movement in the thoracic and abdominal belts. The consequence is that in non-invasive ventilation, belts are not always a synonym of effort. It's a synonym of displacement, not always effort. That's the physiology. Let's review the physiology of the normal belt waveform. The normal belt waveform is like this. From the baseline to the top, corresponding to the inspiration of the patient, and from the top to the baseline, corresponding to the expiration of the patient. In fact, it's a very close to the volume time waveform because, in fact, we are measuring the same parameter. We are measuring volume. And there is an example with the Brea software, and if you remember, the normal waveform of the belts is like the red one you have in the screen. And this is another example of integrated polygraphy. This is the Vivo 45, and you can see here in the arrows that there's a perfect synchrony between the onset of the inspiration in the Bell's channel and in the volume time waveform. What's the information provided by the bells? Three important points. The first one, are the bells in synchrony with the ventilator? That means that we need read in vertical, both inspiratory and expiratory phases. The second question, are the bells in synchrony between them? And the third one, behavior of the bells during the events. Let's review some examples. This first example, are the bells in synchrony with the ventilator? Of course, yes. This is flow, this is pressure, this is thorax, and this is abdomen. And you can see in the vertical lines that is a perfect agreement between the inspiratory onset here in the bells and in the ventilator. And when the expiration starts in the ventilator, corresponds to the expiration in the bells. Second example, are the bells in synchrony in this case with the ventilator? Probably not. Let's review it. Abdomen. In the abdomen, the onset of inspiration in the abdomen is clearly before the ventilator cycle, with a delay around 600 milliseconds. This is a good example of bad synchrony between the bells and between the cycles of the ventilator. Some examples with the Vivo 45 software. Again, let's see the vertical lines. There's some cycles in which there's a perfect agreement between the onset of the inspiration in the bells and in the ventilator. But look at this. In this cycle, there is a first effort here that corresponds to this small waveform in the flow waveform. And here, there's also a small effort here that does not correspond with any cycle of the ventilator. In the next talk, Dr. Carlucci provides the name of this asynchrony. I'm only highlighting that we should read in vertical when we work with belts. Just the opposite example. There is these first 6 cycles are in perfect agreement. This is thoracic belt, abdominal belt, and thoracic belt the onset corresponding to the cycles of the ventilator. But look at this, these 3 cycles. In these 3 cycles, the onset of the displacement of the belts is clearly after the ventilator cycles, leading to this abnormal flow waveform. Then it could be challenging to interpret without the help of the thoracic and abdominal belts. Probably it might be that here the backup frequency in the ventilator and the spontaneous backup in the spontaneous rate of the patient are really close and are fighting one against another. Second questions. Are the bells in synchrony between them? Here we can have 3 main possibilities. The perfect synchrony, physiological aspect of the bells, the abdominal and the thoracic rib cage belt are in synchrony. When there's an increase in the abdomen, there's an increase also in the chest. This is the physiology. It can be a partial desynchrony, or it can be a paradox. When one is increasing, the other is decreasing. This is an example of a good synchrony. When the abdomen increases, the thorax also increases. But this is an example of a partial desynchrony in a COPD patient. And we can acquire a lot of information from this tracing, even without the information of the ventilator, even without the pressure and flow waveform. Look at this. There's an early abdominal onset. The abdomen signal starts clearly before than the thorax. And there is an active abdominal expiration. Look at the slope. There is really a deeper slope than the inspiratory part of the waveform. And there is a slower thoracic emptying in the thorax belt. And I'm sure that if you put the stethoscope here, the patient is surely wheezing. Sure. Paradox. Two different situations. The first, when there's an abdominal weakness. An abdominal weakness, as we can see in the video, there is a movement outwards of the thoracic belt and an inward movement of the abdominal belt, like this. This is the first situation in which we can have a paradox. The second one, just the opposite, the obstruction with the fourth. What's the difference? That the obstruction with the fourth, the abdomen is moving outwards, whereas the thorax, the rib cage, is moving inwards. Like, it's not a very, very good example, but here, for example, you can appreciate here the paradox. The abdomen is moving outwards, whereas the thorax is moving inwards. What are the situations in which the bells are useful? First of all, we can classify the patient if it's well or not well ventilated. If the patient is not well ventilated, the first step is obviously to assess the compliance, but the second one is to assess the leaks. Assessing the leaks is clearly not necessary to have bells. We have a specific channel in each software labeled with leaks. And if you have the information, this information is not necessary to work with bells. But what happens in case of periodic flow reduction or asynchronies? In these two situations, it would be important to have the information about how is the patient breathing. Mainly in situations like this, in upper airway events or periodic flow reduction. We need to know if the patient is fighting or not against the obstruction. If this has clearly clinical implication, if the patient is fighting against the obstruction, we should increase the EPAP. And if it's not fighting, probably we are hyperventilating the patient. It's not only the tracing has clinical implication. Another example of the Vivo 45, during this flow reduction here, there is an absence of abdominal and thoracic movements. In other words, the patient is not fighting against the obstruction. Third box, or third situation, asynchronies. There are sometimes complex tracings like this. For example, look at these 3 points in which it could be important also to have the information of the bells, but this is a topic of the next talk. Well, my message to take home, effort bells provide information about the ventilatory pattern of the patient under NIV, and provide us, we can get information in 3 different points. First one, the synchrony with the ventilator, read in vertical, the synchrony between the bells, and the usefulness, especially during obstruction and asynchronies. Thank you very much.